Good morning, everyone, and welcome to the Arineta Breakfast Symposium at SCCT 2025. My name is Sayali Tarlekar, and I'm the Global Head of Marketing at Arineta. It's always a pleasure to be among friends and champions of cardiac CT. Arineta is fully committed, passionate, and dedicated to advancing cardiac CT. We are the developers of Spotlight and Spotlight Duo, the world's first and only dedicated cardiothoracic CT systems. This is our agenda for today. We have 3 distinguished speakers who will discuss some insightful topics. Our main focus is on the future of cardiac CT, workforce, technology, and clinical outcomes. And we'll take your question and answers at the end. Our vision as a company is to establish cardiothoracic CT as the frontline, non-invasive test for diagnosing, therapy planning, and monitoring cardiovascular and thoracic diseases, the leading causes of death and healthcare costs worldwide. We believe that cardiac CT has the potential to be a transformational technology that can change the course of these deadly diseases. I would now like to introduce you to Dr. Jonathon Leipsic. We all know that Dr. Leipsic does not need an introduction, but I would still like to say a few words about him. Dr. Leipsic is Professor and Chair of Radiology and Professor of Cardiology with the University of British Columbia. Dr. Leipsic is also a Canada Research Chair in Advanced Cardiopulmonary Imaging. He has over 880 peer-reviewed manuscripts in press or in print.
2 worth reading. Maybe 3.
Over 300 scientific abstracts and editor of 2 textbooks. He speaks internationally on a number of cardiopulmonary imaging topics with over 150 invited lectures in the last 4 years. He's also the past president of Society of Cardiovascular CT, 2015 to 2016, and was awarded its gold medal in 2019 and was recently named to the prestigious top 1% most impactful scientist designation by the Web of Science for 6 years in a row from 2019 to 2024. Dr. Leipsic will be talking about scaling a coronary CTA program with a dedicated small footprint cardiac CT. Please join me in welcoming Dr. Leipsic.
Thank you. For those of you who know me, you know that I really hate introductions, but I really appreciate the opportunity to share thoughts with many friends, many mentors over the years. And really, as Doug was mentioning earlier, we have a modest crowd here as far as size. It's early morning Saturday, so really reach out, interrupt, engage. I know my colleagues here on the panel are really here to share our experiences and thoughts, and look forward to the engagement and discussion as the room fills up over time. So the team from Arineta has asked me to share my experiences and my thoughts. To start, disclosures, CT core lab work for most of the structural heart disease trials. I take no compensation for that work. I do give advice to HeartFlow and a modest disclosure from Arineta, although not for this specific talk. They've helped me attend meetings overseas, the Israeli Heart and the ICI, so I'm grateful for that. So needless to say, but I'd like to frame this conversation about our shift in practice back in 2019 when we decided to partner with Arineta and install a dedicated cardiac CT. You know, I know many of us in this room have been passionate about cardiac CT for 2 decades, and I certainly thought that cardiac CT was going to transform our practice and would be rapidly adopted. We saw it be the case in Europe more rapidly, in Canada. Obviously, in the United States, it took a little bit longer until the chest pain guidelines provided a Class 1A indication in 2021. And I think for a whole host of reasons, but primarily, as you'll see from Dr. Boone's practice, you know, the richness of information that it's really providing, as we all know, as far as diagnosing coronary disease, informing risk, and of course helping inform medical management. As Jeff was mentioning earlier, he said that the only indication for a patient that he's seeing not to have a CT, you know, is asystole or something. No, he didn't say asystole, but pretty much if he's seeing a patient, he needs to know. I mean, how do you know what you're treating if you don't know? And I think that's really the power of CT. You know, in my journey with Dr. Taylor and the audience and understanding the role of computational fluid dynamics and physiology, and now, of course, plaque segmentation, these cases come through a dime a dozen. And, it's interesting how in the early days of cardiac CT, I was told that we should, of course, be so much focused on the typicality of angina. And I can tell you that I can share with you all these examples from my Arineta scanner, of course, and I can tell you any clinical presentation you want, and all could be associated with any of these manifestations, either, severe anatomical focal lesion, absolutely bereft of atherosclerosis, focal calcified non-stenotic plaque, or severe aggressive atherosclerosis with a focal anatomical lesion. And so I think the power of CT, as we all know, is really the fact that it's an anatomical truth machine. And to me, the ability to bring cardiac CT to more patients with a scaled, dedicated, small footprint cardiac CT that really afforded us more affordable care on a smaller footprint was really disruptive. As it relates to the Spotlight technology, I think you're all aware of this. Udi Daphne, who was the thought leader behind the science, may he rest in peace, really had a brilliant idea, this concept of scaling the scanner to provide whole heart coverage and minimizing the actual footprint, providing this stereo sort of cone beam parallax technology, but it really does eliminate the artifacts that we see in our scanner. We have excellent acquisition rapidity as well as yield, reducing the detector size and, of course, the cost. And I think for us, in the Canadian healthcare system, the ability to install a scanner that provides whole heart coverage with high temporal resolution, minimal artifacts, low radiation, and a small footprint and at a lower cost was frankly disruptive. I think the costs people look at, they focus, of course, on the actual cost of the acquisition, and that's meaningful. But for us, and I've been in I chair the department at UBC, it's not the same as in the American model, but I'm privy to the cost of installation. And I see Dr. Cohen here or Dr. Boone, installing these scanners, you understand that it's not just what you pay Arineta, of course, it's the install costs. And in the hospital system, that's tremendously expensive. So for us to be able to install in a smaller physical space that we already had seconded that was not adequate or sizable enough for a large footprint CT scanner, and then also to reduce the cost of the installation by roughly 60%, really afforded us greater opportunity to proceed with a dedicated cardiac CT. Importantly, we're focused primarily on cardiovascular work with our Arineta. The question was, is it our primary scanner? It is our primary scanner for structural heart disease as well. With a wide field of view, we do not have the Spotlight Duo, but with a wide field of view, I'm told that the capacity to, of course, screen lungs and do more complete thoracic evaluations is also there. I wanted to just highlight a couple of things for those of you who haven't seen the scanner. If you go visit people who have it installed, it's remarkable. Even though we have one, whenever I go to a practice like either of my colleagues here, and I walk to see the scan room, and you look to. Traditionally, as a trainee in imaging, you look to the CT scan room and you gaze out because you imagine this sort of large, vast room and this large unit, and then you walk to the console and then you have to look down, and it's right in front of you because it's such a relatively small piece of equipment, and to this day, I'm relatively shocked by that. I just wanted to share some clinical cases, our experience, the ability to image complex coronary disease. This is something that, very much been focused on also academically, this concept around planning PCI, that CT, of course, shouldn't be just a tool to rule out coronary disease, but complementing with non-invasive physiology to actually inform planned multi-vessel PCI, as we've seen in the Syntax 2, Syntax 3, Fast Track Cabbage, P3, and now P4 trials. When we looked at our initial experience, this is already old data, which we publish in JCCT, you can see that compared to our standard dedicated cardiac CT, which is a high-end state-of-the-art at the time, only modest iterations with that footprint now, a slight improvement in their temporal resolution, but you could see there was relative equipoise with image quality across a breadth of patients. Here are just some examples from both the literature and our own experience. You could see that I think the opportunity of the scanner is really to marry coverage with temporal resolution. I think many people ignore, and I'm obviously sensitive to the fact that I'm definitely not an engineer, and we have physicists and engineers in the room, but the ability to eliminate, I don't know, should I say Z because we're in Montreal, or Z because most of the audience is American? I'll say Z. Z-axis coverage is important. To limit Z-axis movement is important, right? Because we could talk about temporal resolution, but if the patient has to move to cover the entire heart, there's inherent translation of motion that comes into play. So I think having the whole heart coverage with rapid gantry rotation really affords the opportunity to image in challenging situations. Obviously, patients that are bereft of atherosclerosis, you have the potential to image them even at higher heart rates. I think that's less of a focus for me, though, because in our practice, we're really imaging, as mentioned, all comers. This is our primary cardiac CT. So we're doing patients with prior revascularization. We're doing patients with with extensive calcium. We're doing patients who, are being admitted with infective endocarditis. So we really have to take all comers. Everyone essentially who isn't intubated or acutely unwell, where we need to be able to run a code because the scanner is simply too small to take ventilated and such sick patients. A couple of other examples. You could see that the coronary detail is excellent. The recon algorithms have really matured over the years. The ability to image and image at lower dose using deep learning iterative reconstruction has afforded us further dose reductions and really comparable image quality to large footprint scanners. But let me close with a couple of thoughts around planning complex PCI. We had the SCAI joint symposium yesterday. I don't know why that the image on the top left is distorted, but I really think that this opportunity, and we see it in practices like Dr. Boone and Dr. Cohn and others, where CT is really being brought to the cardiologists. I'm proud of my training. I'm proud that I'm a radiologist. I'm not, I don't deny that, but I really do think for this tool to have its ultimate impact, it really has to get to the patients. It has to get out of the hospitals. It has to also be beside the cath labs. And really used to diagnose coronary disease. Many years ago, I was on a podium and talking about the paradigm to the cath lab, and one of the interventionalists on the podium said that he spent a lot of time diagnosing coronary disease. And I told him that he will continue to do that, but it will be done non-invasively. I can't see, I still see it even in my country, particularly where the penetration of cardiac CT is not great enough, where I still hear of people being told based on stress testing or symptoms that they should go to the lab. I really think it's almost unconscionable, that's harsh, but early in the morning, it's almost unreasonable to send a patient to the cath lab without a CT. And that is because, as you know, you can use this paradigm, and we have senior cardiologists in this room who can share probably hundreds of anecdotes of classic angina, symptoms that are so obviously compelling, functional stress tests that are contributory, and you cath the patient and you find no coronary disease. And the poor interventionalist is muttering under her breath, like, why did I just cath this patient? Or perhaps she finds the most sinister atherosclerosis she's seen in weeks, and she's a new faculty at a prestigious academic institution in the US, and she has to make a decision about complex PCI with an NSTEMI waiting for her outside the room. This is not how medicine should be practiced. So I think that there's a real push from SCAI and beyond to really understand that this is unacceptable, that 50% of patients in the ischemia trial being incompletely revascularized, this is the reality. And then we wonder why there's relative equipoise in revascularization trials versus medical therapy, and we ignore the fact that the paradigm used to decide whether patients go to the lab is broken, and the decisions around revascularization are archaic. Making decisions ad hoc in a lab in Vancouver or in Thailand in the moment, as we saw in the ischemia trial, leads 50% of patients to be incompletely revascularized. And we know incomplete revascularization is associated with a 36% higher hazard for incident MI. So I think the future of cardiac CT is really to explore tools like the Spotlight Duo to really bring CT out of the traditional main departments and really bring it to the patient as it relates to structural heart interventions, electrophysiology interventions and coronary interventions, and to the clinic, the prevention clinic, as we'll hear. But I think for those patients that need medicine, you can really have that certainty. Do they have athero? How extensive is their athero? But if they have anatomical disease, then leveraging tools such as non-invasive physiology for point-specific assessment, you can really empower your interventionalists with a real roadmap of what they may be finding at the time of the cath lab. So let me close there. I think the way forward, I would have predicted that we would have been there much sooner, that we would have seen CTs in the adjacent to the cath labs a few years ago. But I think there's an old saying, I see Dr. Ziffer here, who administers a very large healthcare system. You know, we overestimate the change that we expect to see in a year, right, and underestimate the change that will happen in 10. And I think this change is afoot, right? You hear the interventionalists are no longer seeing this as a competitive technology, but rather what it really is, which is a complementary technology that will hopefully empower them to do their practice better, more efficiently, and with more complete revascularization. So thank you for your attention.
Thank you so much, Dr. Leipsic. I would now like to introduce you to Dr. Jamie Warren. Dr. Jamie Warren is the Vice President of Care Transformation of MedAxiom, part of the American College of Cardiology. Jamie brings more than 25 years of experience in cardiovascular strategy with deep expertise in imaging and diagnostics. She partners with health systems across the country to transform service lines, align operations, and position imaging as a strategic growth engine. A national voice on regulatory change and accreditation, Jamie is known for turning complex data into action and helping teams deliver real-world impact. She'll be talking about the state of the CT tech workforce transformation for cardiac CT growth. Welcome, Jamie.
It's so unfortunate you can't see anything.
Good morning, and thank you for having me. I have no disclosures. So first thing here, we're going to talk about a lot of what you already know, but we're also going to talk about what we're hearing specifically out into the field, and then provide some recommendations of things you can take away today, and then see if you can implement them out throughout the week as you start. So part of MedAxiom, at our core, we are a membership and data organization. And what this allows us to do is gather data across the U.S. market with cardiovascular programs. So think practices, private equity, large IDN, anything from a large healthcare system. We're able to take that data and then use it for benchmarking or even trends. So I pulled data to specifically look at our imaging, and of course, if you look across the five-year trend, it's very loud and clear what is the imaging modality that has the most significant growth. So again, CTA volumes are up 94% in just 5 years. But unfortunately, while we're seeing that increase, we're also struggling from a workforce development perspective and with the staff. And I would say that anyone here in the audience that is performing CTs, we're probably all shaking our head that it's very much a challenge to be able to find that technologist to be able to run the equipment. So unfortunately, if we want to keep scaling, which is what we're seeing in the growth and the trend with cardiac CT, we are going to have to think a little differently on how we staff and educate our staff. So just some additional data points. The first one here, with 25% of our imaging techs are 55 plus with retirements accelerating. So while we're sitting at a point where we're seeing significant growth, we're also seeing our population of our staff that's starting to be looking at retirement, and what are we going to do as we start to move into the next couple of years. Burnout, we see it across the board. Imaging was not all, they're included in the same bucket, unfortunately, and we do see those that are moving outside of imaging, and then with the turnover at 17.5%. We're going to talk a little bit later in this talk about the credentialing confusion, but the thing to think about is that it really is state by state dependent, and the rules change depending on which part of the state that you're sitting in. Lastly, is with our rural areas, it is very challenging to fill our imaging professionals, and that includes in the CT piece of it. We're also finding that there may be table time available, but there's not a CT technologist that can run all of the shifts to perform the patients. So I took a little bit of time over the last month to have some conversations with our members that are actually doing this. So I wanted to talk to the people that are doing daily interactions, those that are the managers, leaders, and I'm saying, okay, what are your top challenges? What are you seeing? And so one of the things that we hear is really being able to keep the people that they have, or being able to be the most attractive employer of choice. That the biggest pieces is kind of pay, sign-on bonuses, retention bonuses, loyalty bonuses. There's a significant struggle with third shift, weekends, call. There's a lot of moving back and forth. I always say it's kind of like robbing Peter to pay Paul. You see the technologists that are moving towards what's the best opportunity. Schedules are also very challenging. Again, it's a scene of the technologist being asked to work in multiple areas. And then one other feedback that came back from one of the managers that I spoke with is, he said, this is basically a team that's always been very small. And the problem is that if one person goes out on vacation, or if they have sick, or for him, he had one that went out on FMLA, he was really kind of just dead in the water and wasn't able to perform the same schedule. He was even at the point that he was going to hire an extra technologist, even though it would show overstaffed on paper, but he knew that he would be able to run his labs, again, completely without having any worries or those if scenarios. And then also the different credentialing timelines. We are seeing that some are hiring those that have graduated, or they're going to cross-train them over into CT, provide them their clinical training while they're paying them as an employee, and then helping them with being able to sit for their boards. The last piece of this, what they said was actually working, especially for those states that allow for a nuclear medicine technologist to sit for their CT boards and work as a CT tech. There is some cross-training of the technologists that are going from a lower volume spec department doing cardiac, moving over into cardiac CT. Also incentives, whether that's a quarterly bonus or based on volume or performance. And then from a structure perspective, that they have found that if they're starting to do an increase in cardiac, if they can find a dedicated team versus a CT tech that does everything, imaging anything from the body from head to toe, but if you could really form that cardiac team, they know what to expect as each day comes. So really kind of digging into the why this matters. The reason why I like this slide is it puts the technologist right in the middle of everything. And I would think for those of us that are sitting out in the field, we understand this. They're really our front line. They're the ones, the eyes and ears of the patient that's coming in and being on that table and having that test performed. It's super important for us to find a team that we can build trust in and that we know we're going to get a high quality care and images that we can then provide back to our readers. So just the next couple of slides are just a couple of things that we're seeing in the field that kind of cause confusion. And the first part is becoming a technologist, becoming a CT technologist. It is really state dependent. So what may be available in New York is going to be totally different than what are the state requirements for Kentucky. So the biggest takeaway from this slide is depending on where you are, especially, so I'm in Louisville, Kentucky. We have to be very careful about, we have facilities in Indiana, but then right across the bridge we have in Kentucky. Those two states, totally different requirements on who can perform the CT. So it's important having that understanding and having someone that is doing that research as you're starting to hire your staff. Talking specifically about who can come in and perform a CT, again, remember state by state, but we're commonly seeing our rad techs and we're also seeing our nuclear medicine technologists stepping into these roles. Starting points, they do have to have their entry-level certification, but then they can go on and do their post-primary pathway to CT. They are going to be required to sit for an exam, whether that's with the ARRT or the NMTCB. They do need to have structured education, clinical experience, and then also the requirements for state licensure. And I know I've said this like 3 times, but this is very important. Just remember the CT certification does not always mean state licensure. And so it's super important to look at your state requirements. The other piece to take a look at is scope of practice. This varies among, again, the different states, and then credentialing is not always aligned with scope. So the biggest piece that I want you to take away with this slide is really to start thinking about what the job is. And one good example is to think about adjunct medications. So at what point does a CT technologist have a role in providing adjunct medications that are included in their scope of practice, but may or may not be recognized from their state perspective? So that may be an opportunity for us in our state to start challenging what the CT tech could do versus having the additional staff in the department. So you've found your technologists, but you want to keep them. The biggest piece, again, is them rotating among different locations within their local community, a lot of them chasing what is the best opportunity to them, what's important to them, whether that's pay or that's work or just kind of what their scheduled daily interaction is going to be. But I like to hit the pause button and really talk about retention, and I'll just tell a very quick story. So for us, some of us that have been in this field for 20, 25 years ago, so let's go pre-PACS, pre-electronic health records. We had paper charts, we had film, we had light boxes. But what we had was our reading physician usually was sitting shoulder to shoulder with us, especially if it was a cardiologist or going in and talking with your radiologist. And you had an opportunity as a technologist that we learned their name, they learned our name, we knew their kids, we knew what they were doing on the weekend. But the bigger piece of this is you built a level of trust, and there was more of a relationship. And I would say for those of you all that have been in the field that long, you can probably even think of the technologists that you had 20 years ago. You could probably even name them by their name. But if we think about today, I would challenge you to say, do you know the name of the technologist that was hired in the last 18 months? A lot of times that answer is no. And so we've kind of slowed down on building that relationship that is super important. So I don't have the immediate fix. I'm not saying that we have time to go spend hours and hours inside of an imaging department, but I would say if you have the opportunity to go down and meet the staff, learn their names, if you need some coffee, the coffee is the best down in your imaging department. Go get some down there and then drink your coffee and have that conversation with them. The other piece with becoming the employee of choice is really thinking beyond pay. Yes, pay is super important, but it's also important on what their life is going to look like as they're in the job. They may be interested in cross-training opportunities. They may want support from a credentialing perspective. Flexible schedules. We have always done it the same way over and over again because that's the way we've always done it. But now is the opportunity to really think about, can we get flexible with our schedules to meet the demand of the staff that's coming in? If you have something that is a decision point, involve your technologist in it. It just provides them an opportunity to sit at the table, provide their voice. What they say may not be the ultimate solution, but again, being able to say that they provided input goes a long way. All right, this last little slide right here, what I'm going to say to you is this is your low-lying fruit. Technician versus technologist, especially in the US market. If you walk into a room with your technologist and you start referring to them as technicians, you're going to see them do this. They're going to put their head down, they're going to shake their head a little bit. If you think about professional titles, a CT, even though we commonly shorten it to CT Tech, they're technologist. So I would just say low-lying fruit, take the opportunity to look at your job descriptions, how they're being worded, what's the verbiage that's coming through, and properly use that terminology. And then use real-world language with your CT technologist. So if you're sitting in a hospital and you're speaking kind of in a bedside nursing language, really think about how this applies down into the imaging department so that they don't feel like, oh, well, they're not talking about me, so they're checking out. Last couple slides here, just remember that one scanner does not equal one tech. There are multiple pieces when it comes to performing a cardiac CT on your patients. And that may be from taking your history, starting your IV, getting them on the table, but it's even beyond that to your post-processing. So each piece of that, you may become more efficient depending on your different staffing models. And then the last piece here, I'm going to give you a little bit of homework. What I would plead for you to do is that when you get back to work on Monday or Tuesday is go find your workforce development person. Go and plead the case of it is very important that today we start a campaign really highlighting what it means to be an imaging professional. Your workforce development are going to go into your high schools and talk to your juniors and your seniors about what career advancements. So a lot of focus today is more on the bedside nursing because that's kind of the largest of our healthcare professionals. But we've really kind of met critical mass within imaging professionals that we need an incoming pipe. So again, that workforce development person can walk into the high schools, but they can also start to have conversations with your local schools and even the schools that they can provide that remote educational piece. So that is all I have. Thank you all very much.
Jamie, thank you so much. I would now like to introduce you to Dr. Jeffrey Boone. Dr. Boone is an internationally recognized expert on the effects of mental health on the heart and the prevention of heart attack and stroke. Dr. Boone is the founder of the Boone Heart Institute in Denver, Colorado, as well as Boone Heart Imaging, a leader in the use of CT and ultrasound imaging in the prevention of heart disease. Now here's the fun part. Dr. Boone works as a consultant in preventative cardiology for the Denver Broncos and San Francisco 49ers of the NFL, the Colorado Rockies of Major League Baseball, and the Atlanta Hawks of the NBA. Dr. Boone sat on the NFL's cardiovascular committee for a decade and created the NFL Alumni Association's cardiovascular screening program, an ongoing investigation into the cardiovascular health of former NFL players. As an international lecturer, Dr. Boone has spoken to thousands of healthcare professionals around the world. Dr. Boone's unique clinical approach focuses on aggressive prevention of cardiovascular disease, including the evaluation of the early clinical use of the latest cardiac imaging techniques. Dr. Boone is going to discuss the eradication of heart attack, the role of coronary CTA. Welcome, Dr. Boone.
Great to be with you here today. An exciting panel to be a part of. Thanks for the excellent discussions. I want to move our focus to sort of a history of preventive cardiology. I went to medical school to become one that tries to prevent heart disease. When I finished that in the late 80s, we began to look at the world of risk factors. We had very few drugs and very few tests that were any good at that time. One of my motivations as an MD was just to get people to buy into all the lifestyle things that are now available with data about smoking cessation, exercise, nutrition, weight control, stress management, all that very important. But as I began moving through the late 80s, I began to notice that we're trying to treat a disease that we haven't measured. How do you treat a disease that you can't even measure? Worked at the Cooper Clinic in Dallas. Ken Cooper kind of pioneered jogging, was one of the first people in those days, in the 80s. It was controversial to do an asymptomatic treadmill. So he was pioneering that, but still didn't look at the disease very well in that process. And the disease is one that sort of grows through a variety of physiologic, biochemical, anatomic processes. But it's been growing for 30, 40, 50 years by the time you see it on a coronary CTA. How do we find it earlier and go after it, both anatomically, physiologically, biochemically, even genetically? In the late 80s, Seymour Glagoff showed us that it's a disease of the wall, not the lumen. I thought that would change everything. That's 40 years ago in 1986, showing the disease grows in the wall of the blood vessel. And it's a long time before it invades the lumen. Now, all of this incredible conference discussing the process of start to finish of this disease, I think the greatest possibility to save lives is offered at the earliest stages in this process. At the Cooper Clinic, every now and then a patient would die jogging out on their tracks. And you all remember the book with Jim Fix, Fitness Isn't the Total Answer. And I talked to Dr. Cooper about this new technology, calcium scoring, that has just been developed. It didn't take him long to realize that that actually finds the disease. And even in those days, it's hard to academically not say that any calcium, even a score of 1, is the disease. Now you've got the disease, risk factors fall into line. Everything from cholesterol to blood pressure falls into line, and patients can understand the disease. Very complex to understand. Cholesterol, lifetime of treatment, blood pressure, those are hard concepts. But if you show them disease, it changes everything. So that was an exciting time. If you've lived in Dallas, great city, but it's hard to move there from Denver on August 1st. 102 degrees, bugs the size of your fist. If any of you are from Texas, sorry, but my wife didn't want to stay in Texas, so we moved back to Colorado. But Cooper had a calcium score. So in my work in the late 80s in Denver, the 90s, I told people to fly to Dallas to get your calcium score so we'd know about your plaque. Treadmills, echoes, all that was nice, but this was beginning to be something quite a threshold. Then I discovered the carotid. The carotid is a window. It's just a bridge between the brain and the heart. I-70 running through Colorado. 15 miles one way is about the same as 15 miles the next way, so we could use that. And I think we've died on the wrong battlefield with carotids. It's about a binomial plaque-no plaque and not IMT. IMT is nice, but it doesn't really change the world. If you could take obsolete echo machines, obsolete ultrasound machines, and binomial decide plaque-no plaque in a carotid, you could test thousands of people a day for free, and then decide who needs CTA. So that became a process we started looking at. And then once you've looked at the disease, then the next step is to redefine significant and aggressive. Significant disease we often think involves chest pain, involves ambulances, emergency rooms, aggressive care, there's blood on the floor, cath labs, totally different paradigms. Significant disease is the minute I find plaque anywhere. Might be even a calcification on the breast, the mammary artery in the breast exam. A microburst in the brain, that's atherosclerosis. Aggressive treatment has very little to do to intervention. I would say a million people need FFR, 100 million people need plaque analysis. And now we've got moving through the process, incredible technologies that you're all expert in to accomplish that. So then my next step was, well, the imaging with the ultrasound doesn't require a huge machine and a lot of other issues. So I began measuring carotids, and it's pretty easy. You know, if it's a 9 millimeter carotid and it's a 3 millimeter plaque, my math tells me that's about a 33% blockage. So you can even start looking at percent stenosis. We're starting to kind of look at this in Denver as looking at the real disease, can we find it? Then the next step is causation. Why is it there? Risk factors, genetics, vulnerability can be both biologic, physiologic, and from a blood flow perspective, we can determine vulnerability. And then the treatment is where we're lacking. All of you in your world, once you see those images, we've got to empower very aggressive treatment. And we've got 10 to 12 tools in our toolbox that have already been proven. We actually don't need much more data. Your scans are so accurate. The treatments are so good. We put those together. We can, I believe, eradicate cardiovascular disease. Now, the other thing about calcium scoring, again, as we've seen in this conference, wonderful thing to define the disease and be very aggressive with your definition, because 20% of the assessment of plaque is calcium, so you never know how much is non-calcified or not, but it certainly opens the door to aggressive treatment. Then we heard yesterday about carotid imaging, and Dr. Fuster at Mount Sinai just published this article that any carotid peripheral plaque burden is a predictor of all-cause mortality. So if I see plaque in the carotid, that predicts death independently. And then serial testing, growth of that carotid plaque, also independently predicts all-cause mortality. Very simple thing that might lead to CT scans. Now, in our world, we have our own Arineta Spotlight Duo, wonderful test just down the hallway. And as Jonathon said, in my clinic, if you're alive at 40, you're getting a CT angiogram. If you're dead by then, you're not going to get one. Because people come to us for the best. We didn't go to medical school to be average or anything. That's the best. But how do we get the best to everyone? So in Denver, again, we go to a corporation, 1,000 employees. We'll take one of our carotid scans and test the entire corporation for carotid. Anybody with any plaque can go into an easy algorithm of what to treat with aspirin, statin, all the way through GLP-1s and SGLT2s. You can help empower their doctors with that. But pick your number, 20% block, 25%, 30%. At a certain point, that corporation would then have, out of that 1,000 people, maybe 300 that have enough plaque that need a CTA. And that's what the company might be paying for, even in a cash-priced world. The other thing about getting the payers aren't interested in this. Payers are interested in saving money. It'll take a long time to get them to pay for it. I think the future of cardiac CT might be cash. You don't need one every year. You need one at age 40, and if you need one again at age 45, you budget what you pay for a Starbucks once a month would cover the cost of that if you're paying cash for such a scan. So I think we've got to assume the patient may want more than just what might be covered by their insurance policy, which is interested in the cost of their health, not their health. So I think always looking outside the box at how you can get these things funded, very exciting. We're messing around with something called the Boone arterial risk, which would be the bar score, which is sort of predicting who might need CTA by just simple carotid plaque assessments. So here we are back now, we're in the 2000s again, and I come across a friend of Jonathon, Simeon Abramson, and he's now moving beyond calcium score in the early 2000s to doing something called CT angiogram with grayscale. And we see this kind of image with obviously a LAD lesion with soft plaque. I would get Simeon to give me an exact number. My patients want exact percent stenosis, not ranges. And so, 71% might be the bell-shaped curve in the middle of an estimation of plaque here. But look at that, calcium score of 260. But we would go through the grayish soft plaque with a Hounsfield unit cursor and find 20 to 40 units. And then in these days, with 2007, our best therapy was rosuvastatin. So with Crestor and Lipitor-based therapy, over 9 years, look what happened to that lesion. The calcium score went from 260 to 973, but in Hounsfield units, now we could only find 90 to 110. So that became most exciting. And then in our hospital, after looking at this case, seeing that we normalized everything that we could think of, we lowered his LDL from 158 to 69. This was pre-PCSK9. ApoB we dropped, blood pressure, everything we could think of we treated. And he also had carotid plaque. But then one of the radiologists, who's now one of the radiologists at MD Anderson, showed me this, some sure plaque technology that was starting to color code Hounsfield units. Probably the precursor for Clearly. The hospital then didn't renew the license on this, so we couldn't do this for very long. But very exciting possibilities to look at this. And certainly with Stanford and others doing virtual histology, IVUS, grayscale, showing problems, non-ischemic vessels. You see then the color coding of the lipid-rich vulnerable plaque, and then you see death and autopsy. So finding that early, even before ischemia, very exciting, very important, redefining significant disease and aggressive care. Even non-ischemic, this can be very dangerous. Then we got our own Arineta Spotlight Duo scanner after working for many years, trying to get cash pay prices at the university and various hospitals. And that has been a very revolutionary thing to add to our practice. So pretty much everyone gets one of these, again, depending on risks and other issues. But exciting to have that, as has been mentioned, very efficient, great technicians that we've got, very good footprint where the scanner has been placed together. And now I've got a vision of all of it coming together. I can image with color-coded plaque density assessments. This would be some of the first images we got, and now discovering Clearly to be able to give me various densities, percent stenoses. I love it. It clearly gives me luminal diameter stenosis and also area stenosis. So you can see in the bottom left, if I want to scare a patient to death, I'll tell them they've got a 61% blockage. But that's Glagoff changes of remodeling, so it's actually only 37%, I believe, here. So you can actually tell the patient the wall of the artery is being invaded. It's almost like a rattlesnake swallowing a rat. It goes both directions, inward and outward. Much like hot lava, various analogies. The black turns to white like diamonds hardening. The yellow turns to white as it develops, and blue in that case, as it's almost like a lava flow in Hawaii, healing and then becoming solidified, calcified, and then you build a golf course on top of it, which is the endothelial improvements that occur with CRP, LPPLA2, and other myeloperoxidase and other lab values that would show stabilization. So this is the first person that we had that we actually tested a year later after introducing PCSK9 inhibitor therapy. Started him on evolocumab, and his initial evaluation, again, a 42% carotid blockage, 61% area blockage on the Arineta Clearly CTA. LPPLA2, 224. That's like a plaque-specific C-reactive protein, ought to be below 100. LDL 106, kind of like everybody. Everybody's kind of got normal cholesterol. Half the people, 3/4 of the people having heart attack have relatively normal cholesterol. But now the cholesterol means an entirely different thing when you begin to look at the vulnerability of the plaque and the amount of plaque that they have. Carotid IMT was normal in this gentleman. So here was his treatment plan. We started PCSK9 therapy. Can I get a glass of water? Oh, here, I've got it. Brown and Goldstein discovered these blue cholesterol receptors in 1985. They won the Nobel Prize for that. These receptors clear cholesterol particles. So as soon as I see plaque, again, the best technologies, I want to evaluate that plaque, but I also want to look at the best medications to reverse this process. Statins are great. This just adds even more of an aggressive approach. Actually, the Amgen did a study and even named it after Glagoff, showing that aggressive care actually can reverse, control, certainly densify the plaque. So we want to empower that, and often I think we have now 3,000 patients with PCSK9 inhibitor added to their statin-based therapy, along with other peripheral processes. Brown and Goldstein, when they accepted the Nobel Prize in Stockholm, actually said in their speech, that the human probably only needs an LDL of about 30, and that's what's easily accomplished now. I've heard the Lipid Society of India now, their goal is 15 or less in people who've had major coronary events. So that drug has added to things. We added to this gentleman, and he got his LDL now from 106 down to 7. Again, both Odyssey outcomes, all of the data would show that you can't really get too low with the cholesterol. And as you saw that technology, the cholesterol receptor grabs the particle, takes it out of the bloodstream, puts it into the factories that use cholesterol. So when I use a PCSK9 added onto a statin, I'm not even lowering their cholesterol. I'm just getting it out of their bloodstream where it causes disease. So LDL down to 7. LPPLA2, which is the measurement of the hot volcanic, the hot red type of plaque, goes from 224 to 39. All the other parameters come into to great focus. And here's the plaque 9 months later. You can begin to see the blue densification of the plaque. We've got the beginning of the healing process, and that's for everybody in North America that can have access to this process. So you see that his plaques in the carotids reversed, in the femorals they reversed, the cholesterol 106 down to 7, the LPPLA2 224 to 39. Great process, and even in this regard, the percent stenosis seemed to go down as well, with the luminal stenosis now down far below what it had been, from 37 down to 19%. And that occurred in like 9 months with aggressive care. Now, as we've been around longer, most of our patients have been asymptomatic. Most of our patients, I believe it's almost a failure if we need any stent or intervention or bypass surgery. But now we're getting sicker and sicker patients sent to us. They find about what we're doing. So here's clearly on a 72-year-old veterinarian. And now you can see we've got a huge amount of plaque estimated by 55% blockage, area blockage 89%. Asymptomatic, no chest pain, normal treadmill, 72-year-old vet, hikes around Colorado up in the mountains, doesn't want to do a stent. So several years later now, just in the last few months, began having chest pain up in Breckenridge. Now with the addition of, clearly, we have now the binomial above or below 0.8 FFR. Here's a longitudinal cross-section. We've been treating him aggressively, but not enough to reverse that plaque. And now we have heart flow with the excellent FFR reading here, dropping from 0.99 to less than 0.5 very quickly. Had a stent here. We sent him to John Messenger at the University of Colorado just a few months ago. That was that lesion that we could not reverse, and now a stent in that process, and now he's off hiking in the mountains, nearly age 79 now. Now, final case that put all this together is interesting. So here's a typical Colorado person. Now, in Colorado, the trouble is everybody thinks they're healthy, but they're not. They've not been imaged unless that has occurred. We don't know what's inside this. So this is a successful guy, used to be an Olympic skier. Very highly competitive person, had a calcium score of 0 at age 60. So we've all seen what that might mean, and he was scanned by our Arineta Spotlight Duo scanner. As he was referred to me, I said, that calcium score of 0 is great, but let's get into the whole idea of how you're doing anatomically, physiologically, biochemically, genetically. It was screening of plaque both through those mechanisms across the board. And so we scanned him, and we also were able to apply clearly technology to him. And then we also added heart flow and elucid. So I have several patients where we used all three technologies because oftentimes they each show us something different. So his first clearly analysis, 68% LAD lesion. Heart flow showed an FFR of 0.79. And elucid, which is now elucidating the possibly most vulnerable spot, because no matter how much plaque you have, the one plaque that kills you is a plaque that might be vulnerable. So here's the initial clearly analysis, 68%, 89% area blockage. Here's the FFR 0.79 with heart flow. And then getting back to my virtual histology history and interest 20, 30 years ago, now we've got a virtual histology assessment of the plaque. So here would be the elucid assessment, and you see that red hot plaque right in that one area of greatest stenosis. Very interesting. Now, normal stress echo, this was done January 6th this year. Normal stress echo, no chest pain, shocked about the amount of plaque he has. We started him on aspirin, statin, ezetimibe, PCSK9, colchicine, Xarelto. icosapent ethyl, and spent 6 months watching him. He wanted to get scanned again 6 months later. What do you think might have happened? So this is sort of the most cutting edge of using a great device to evaluate the plaque. We found that here was his initial amount of elucid determined low density plaque, 23.6 cubic millimeters of plaque. When we repeated it after that therapy, the amount of lipid-rich necrotic core went from 23.6 cubic millimeters to 14.9 cubic millimeters in 6 months. LDL cholesterol 129 down to 1. Atherogenic particles 91 down to 9. Luminal stenosis stayed the same at 68%. Heart flow got worse from 0.74 down to 0.74 from 0.79. So we did send him for a stent, but very interesting how all these technologies come together. So find plaque, treat it aggressively, and then empower your treating physicians, if you're not the one to do that, to be very redefining of significant disease and aggressive care. And I think we can move forward to the possibility of actually eradicating heart attack. Again, expanding these technologies across all age groups, all comers with all risks, I think is going to put us in a position to evaluate and treat appropriately across the board. So that's all I had today. Thanks for your attention, and we'll look forward to some questions.
Yes. Thank you, Dr. Boone. Thank you to all our speakers. We'll start with Q&A. If you have any questions, please go ahead. There are mics on both sides of the room, so let me know if you have any questions.
Dr. Boone, very nice presentation. Everybody, great job. Anyway, if you had to pick one sort of post-scan arterial analysis tool, not everybody can get treated.
Yeah, you're right.
What would you?
Well, I like.
Another question.
Yes, I thought I want to float all boats, and I love them all. I tell people it's like I've had 3 triplets, identical triplet girls, and they're all just beautiful. But each one's a little different. Now we are lucky in a position where the more significant disease I'm getting all 3 because they give me something different. I would have to say my initial patient interface is stimulated most at this point by Clearly, where I get incredible accurate types of things. Like I know it's probably not kosher to say you've got a 51% blockage, but my patients like that. They don't like the range of, it's 50 to 70. I figure give me that number at the middle of a bell-shaped curve. And then we got the color coding, the presentation, fantastic as I approach that process. But they're all getting more, my triplets are getting, better. They're learning from each other. And so I think the heart flow plaque analysis, the heart flow FFR, the best. I'm loving what I'm seeing from Elucid, but they can't give me percent stenosis or FFR yet. So I love them all, but I would have to say Clearly is the thing that we do on all of our patients. And then all of you hardworking radiologists, cardiologists that read this stuff, man, I've got cliff notes right in front of me. I don't know if you, in college, I got mostly A's and I never read a book. I just read the cliff note summary. So if I were you, I would take these AIs and all of a sudden you could be the supervisor of vast numbers, thousands, if not millions of tests, giving the right data. And the AI just doesn't make mistakes. And when we've already gotten an award for excellence because of the quality of the Arineta, and then the ultimate processing in that area. So that's kind of my thought. Are you in the same way?
Yeah, why don't we do that? We can test that population.
I only show that on a few cases. Most of the time is.
Follow-up question related to the second talk is how's your staffing for your phenomenal scanning? Tech staffing.
Yeah. Your question for me?
Yeah.
We were so lucky. We stole a bunch of Simon Med employees because we have a great working environment. And I think all of us ought to be, all of medicine ought to be like what they use the word concierge, meaning everybody ought to be treated like your family. And that's how our clinic is. And
I've seen that, yeah.
as she said, you know, you've got to, the key thing, even for our employees, is probably not how much we pay them, but how much they love working in this situation. So you've got to make their life just incredible, and they just don't leave. And so,
You know, I would say just in the hospital system to share, and I've seen your practice as well, Ben, I think this is a real opportunity to create a forum for, as Jamie was highlighting, people feel really empowered, treated. I mean, I see your team. I mean, you love them, and they feel like, you know, they're really your partners in delivering this care. And I think in the hospital system, though, as well, in a very constrained, rationed, not rational, healthcare system we have in British Columbia and in Canada, is having this niche area where they can really impact the patient care. They still rotate through the general department, but I think they really value this opportunity to really be experts in the cardiac space and really partners in the chest pain clinic and the prevention and the valve clinic and getting to know these patients. And I think it's a great lever to retain people because we know how challenging the technologists' jobs are also in a general hospital, you know, dealing with stroke and then trauma and combative patients. And so I think it's really, for us, it's been a wonderful opportunity to drive retention.
Any more questions?
You can just say, if anybody's contemplating looking at an internet scan, come talk to me, come visit me in Los Angeles, see how we operate, see how we work, and we'll
Yeah.
follow them up.
And also stop by our booth today. We are in booth 410 when you get a chance. And if you haven't said hi, come say hi to us. And thank you so much for taking time and coming to our symposium. Thank you very much, everyone.